Physiology of pain. Guyton and Hall Textbook of Medical Physiology. Chapter 48. Somatic Sensations, 2. Pain, headache, and thermal sensations. Pages 598 to 609. Many, if not most, ailments of the body cause pain. Furthermore, the ability to diagnose different diseases depends to a great extent on a physician's knowledge of the different qualities of pain. For these reasons, the lecture is devoted mainly to pain and to the physiologic basis of some associated clinical phenomena. Concept of pain. Concept of pain. Definition of pain. Currently the most popular is definition of pain given by the International Association for Study of Pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential damage to tissue or described in terms of such damage. Pain is a protective mechanism. Pain is a distressing feeling often caused by intense or damaging stimuli. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. Pain motivates us to withdraw from damaging situations, to protect a damaged body part while it heals, and to avoid similar experiences in the future. Most pain resolves once the noxious stimulus is removed and the body has healed, but it may persist despite removal of the stimulus and apparent healing of the body. Sometimes pain arises in the absence of any detectable stimulus, damage, or disease. Pain is the most common reason for physician consultation in most developed countries. It is a major symptom in many medical conditions, and can interfere with a person's quality of life and general functioning. People in pain experience impaired concentration, working memory, mental flexibility, problem solving and information processing speed, and are more likely to experience irritability, depression, and anxiety. Simple pain medications are useful in 20% to 70% of cases. Psychological factors such as social support, cognitive behavioral therapy, excitement, or distraction can affect pain's intensity or unpleasantness. Pain occurs whenever any tissues are being damaged, and it causes the individual to react to remove the pain stimulus. Even such simple activities as sitting for a long time on the ischia can cause tissue destruction because of lack of blood flow to the skin where it is compressed by the weight of the body. When the skin becomes painful as a result of the ischemia, the person normally shifts weight subconsciously. But a person who has lost the pain sense, as after spinal cord injury, fails to feel the pain and, therefore, fails to shift. This soon results in total breakdown and desquamation of the skin at the areas of pressure. Avoid sitting for long periods of time. Sitting puts pressure on your pelvis. If you're going to stay in one spot for a long time, try laying flat in bed so your pelvis is in a neutral position. Even sitting in a recliner puts your pelvis in an unnatural position. Types of pain and their qualities. There are two main kinds of pain: 1. Physical pain, 2. Psychogenic pain. By cause, physical pain is classified into three categories. 1. Pain caused by external factors, except for pain caused by excessive adequate stimulations of sensory organs, for example, of vision, of audition. 2. Pain caused by internal processes. 3. Pain associated with damage to the nervous system, in particular to its afferent part. Pain caused by external factors, except for pain caused by excessive adequate stimulations of sensory organs, for example, of vision, of audition. Such pain is characterized by the following features: it is superficial, brief except for the cases associated with breakage of the integrity of skin. Such pain can be easily localized and its cause identified. The external factor can be eliminated. The nervous system remains undamaged, its peripheral apparatus and central mechanisms remain intact. Pain caused by internal processes. This kind of pain is associated with stimulation of any kind of receptors by different mechanisms. The resultant train of afferent impulses is perceived as pain. Skin usually does not participate in initiation of this pain, unless it is damaged or reflects pain. It is often impossible to localize this pain, identify its cause, and eliminate it partly or fully. It is of much longer duration. Here, the nervous system remains undamaged, because the focus of the pathological process is distal from receptors. Besides, afferent fibers retain the normal conduction, and pain-modulating mechanisms function normally. By the type of the involved tissue, this kind of pain is categorized into ectodermal, mesodermal, endodermal pain, and also pain caused by excessive loads on muscles. 3. Pain associated with damage to the nervous system, in particular to its afferent part. Although such pain is often accompanied by sensations on skin, it is nevertheless difficult or impossible to correctly identify the external causes and to localize the source of pain. This pain is long-term, may persist for years, and elimination of its source is impossible. The nervous system is damaged, defects in the conducting peripheral or central pathways are noted, as well as disturbances in pain-modulating mechanisms. Damages causing this pain are proximal to receptors of peripheral nerves, spinal cord, or higher nervous centers. This kind of pain may be local or systemic: neuralgia, causalgia, phantom pain, thalamic syndrome. Besides, physical pain may be primary, or epicritic, rapid, acute, piercing. For example, pain caused by pricking the skin with a needle. It has a precise localization, persists for some time after elimination of the stimulus, does not elicit emotional response. Secondary, or protopathic, pain, slow, intolerable, burning, which appears in 0.5 to 1s after the primary pain, has no distinct localization, persists for some time after elimination of the stimulus, is accompanied by alteration in the functions of the cardiovascular and respiratory systems, may affect the personality, way of thinking. Secondary pain also includes dull pain in the visceral organs and in deep somatic structures. Fast pain and slow pain. Pain has been classified into two major types: fast pain and slow pain. Fast pain is felt within about 0.1 second after a pain stimulus is applied, whereas slow pain begins only after 1 second or more and then increases slowly over many seconds and sometimes even minutes. During the course of this lecture, we shall see that the conduction pathways for these two types of pain are different and that each of them has specific qualities. Fast pain is also described by many alternative names, such as sharp pain, pricking pain, acute pain, and electric pain. This type of pain is felt when a needle is stuck into the skin, when the skin is cut with a knife, or when the skin is acutely burned. It is also felt when the skin is subjected to electric shock. Fast sharp pain is not felt in most deeper tissues of the body. Types of pain and their qualities. Slow pain. Slow pain also goes by many names, such as slow burning pain, aching pain, throbbing pain, nauseous pain, and chronic pain. This type of pain is usually associated with tissue destruction. It can lead to prolonged, unbearable suffering. It can occur both in the skin and in almost any deep tissue or organ. Chronic pain, physical pain, persisting for a long time in some patients with chronic diseases, is characterized by complex nervous mechanisms at the emotional, affective, and behavioral levels manifested by reactive depression, which makes an individual disabled and radically changes his/her life. Psychogenic pain is associated with psychological and social factors, such as emotional condition of an individual, a specific situation, cultural traditions. It has no clearly defined onset and no evident reason. The nature of psychogenic pain remains unclear in many aspects. Often the acuity of pain as described by the patient does not correspond to his/her behavior. Pain may disappear at night. Pain may have poorly defined localization or may change localization, which sometimes does not correspond to the dermatome or the site of referred pain. Besides, psychogenic pain is not associated with external stimuli and can vary with the mood. It can be eliminated by intake of antidepressants and use of other means that relieve emotional stress. It follows from the above that the concept of pain includes painful stimulus informing an individual about a past or a forthcoming damage to tissues, personal or individual perception of a harmful factor, complex of responses aimed at protection of an organism against a noxious factor, category of experience based on numerous events accompanied by sensory and emotional conditions. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Write the answer in the general chat of the BBB. Pain theories. Pain theories. As long as humans have experienced pain, They have given explanations for its existence and sought soothing agents to dull or cease the painful sensation. Archaeologists have uncovered clay tablets dating back as far as 5000 BC which reference the cultivation and use of the opium poppy to bring joy and cease pain. In 800 BC, the Greek writer Homer wrote in his epic, the Odyssey, of Telemachus, a man who used opium to soothe his pain and forget his worries. While some cultures researched analgesics and allowed or encouraged their use, others perceived pain to be a necessary, integral sensation. Physicians of the 19th century used pain as a diagnostic tool, theorizing that a greater amount of personally perceived pain was correlated to a greater internal vitality, and as a treatment in and of itself, inflicting pain on their patients to rid the patient of evil and unbalanced humors. This lecture focuses both on the history of how pain has been perceived across time and culture, but also how malleable an individual's perception of pain can be due to factors like situation, their visual perception of the pain, and previous history with pain. Early theories. Because of the only relatively recent discovery of neurons and how they conduct and interpret signals, including sensations such as pain, within the body, various theories have been proposed as to the causes of pain and its role or function. Even within seemingly limited groups, such as the ancient Greeks, there were competing theories as to the root cause of pain. Aristotle did not include a sense of pain when he enumerated the five senses. He, like Plato before him, saw pain and pleasure not as sensations but as emotions, passions of the soul. Alternatively, Hippocrates believed that pain was caused by an imbalance in the vital fluids of a human. At this time, Aristotle did not believe that the brain had any role to play in pain processing, but rather implicated the heart as the central organ for the sensation of pain. He was the principal advocate of the cardiocentric theory of the soul, and differed in this from the encephalocentric proposals of, among others, Hippocrate, who explicitly considered that the brain was the source of our pains, grief, anxieties, and tears. The dichotomy between encephalocentrists and cardiocentrists extended well into Renaissance, the Aristotelic cardiocentric vision being the one that prevailed among philosophers, although disputed by eminent doctors such as Galen. Middle Ages and early modern period. In the 11th century, Avicenna theorized that there were a number of feeling senses including touch, pain, and titillation. In a religious context, pain could be seen as a punishment or a trial from God. But this religious conception did not prevent early modern physicians from being concerned by the problem of pain. They tried to cure it with painkillers called anodynes. They discussed the problem of the phantom pain, described in the 16th century by the surgeon Ambroise Paré, and they proposed rich descriptions of the signs of pain. In his Treatise of Man, published post 1664, René Descartes theorized that the body was more similar to a machine, and that pain was a disturbance that passed down along nerve fibers until the disturbance reached the brain. This theory transformed the perception of pain from a spiritual experience to a physical, mechanical sensation, meaning that a cure for such pain could be found by researching and locating pain fibers within the bodies. Specificity theory. The specificity theory, which states that pain is a specific sensation, with its own sensory apparatus independent of touch and other senses, emerged in the 19th century, but had been prefigured by the work of Avicenna and Descartes. Scottish anatomist Charles Bell proposed in 1811 that there exist different kinds of sensory receptor, each adapted to respond to only one stimulus type. In 1839 Johannes Müller, having established that a single stimulus type, example a blow, electric current, can produce different sensations depending on the type of nerve stimulated, hypothesized that there is a specific energy, peculiar to each of 5 nerve types that serve Aristotle's 5 senses, and that it is the type of energy that determines the type of sensation each nerve produces. He considered feelings such as itching, pleasure, pain, heat, cold, and touch to be varieties of the single sense he called feeling and touch. Müller's doctrine killed off the ancient idea that nerves carry actual properties or incorporeal copies of the perceived object, marking the beginning of the modern era of sensory psychology, and prompted others to ask, do the nerves that evoke the different qualities of touch and feeling have specific characteristics? Specificity theory. Filippo Pacini had isolated receptors in the nervous system which detect pressure and vibrations in 1831. George Meissner and Rudolf Wagner described receptors sensitive to light touch in 1852, and Wilhelm Krauss found a receptor that responds to gentle vibration in 1860. Moritz Schiff was first to definitively formulate the specificity theory of pain when, in 1858, he demonstrated that touch and pain sensations traveled to the brain along separate spinal cord pathways. In 1882, Magnus Blix reported that specific spots on the skin elicit sensations of either cold or heat when stimulated, and proposed that the different sensations of cool and warm are caused by stimulation of different, specific receptors in the skin. Max von Frey found and described these heat and cold receptors and, in 1896, reported finding pain spots on the skin of human subjects. Von Frey proposed there are low-threshold cutaneous spots that elicit the feeling of touch, and high-threshold spots that elicit pain, and that pain is a distinct cutaneous sensation, independent of touch, heat, and cold, and associated with free nerve endings. Intensive theory. In the first volume of his 1794 Zoonomia, or The Laws of Organic Life, Erasmus Darwin supported the idea advanced in Plato's Timaeus, that pain is not a unique sensory modality, but an emotional state produced by stronger than normal stimuli such as intense light, pressure, or temperature. Wilhelm Erb, in 1874, also argued that pain can be generated by any sensory stimulus, provided it is intense enough, and his formulation of the hypothesis became known as the intensive theory 3. Alfred Goldscheider, 1884, confirmed the existence of distinct heat and cold sensors, by evoking heat and cold sensations using a fine needle to penetrate to and electrically stimulate different nerve trunks, bypassing their receptors. Though he failed to find specific pain-sensitive spots on the skin, Goldscheider concluded in 1895 that the available evidence supported pain specificity, and held the view until a series of experiments were conducted in 1889 by Bernhard Nonin. Nonin had rapidly, 60 to 600 times/second, prodded the skin of tabes dorsalis patients, below their touch threshold, example with a hair, and in 6 to 20 seconds produced unbearable pain. He obtained similar results using other stimuli including electricity to produce rapid, sub-threshold stimulation, and concluded pain is the product of summation. In 1894 Goldscheider extended the intensive theory, proposing that each tactile nerve fiber can evoke 3 distinct qualities of sensation, tickle, touch and pain, the quality depending on the intensity of stimulation, and extended Nonin's summation idea, proposing that, over time, activity from peripheral fibers may accumulate in the dorsal horn of the spinal cord, and spill over from the peripheral fiber to a pain-signaling spinal cord fiber once a threshold of activity has been crossed. The British psychologist, Edward Titchener, pronounced in his 1896 textbook, excessive stimulation of any sense organ or direct injury to any sensory nerve occasions the common sensation of pain. Pain receptors and their stimulation. The first statement of the gate theory is that transmission of nerve impulses from the afferent fibers to the neurons of the spinal cord that further transmit impulses to the brain, is modulated by the spinal gate mechanism, which is a system of interneurons in the gelatinous substance of the spinal cord, the second and the 3D laminae of the dorsal horn. It was found that neurons of these laminae receive axon terminals from numerous thin and thick afferent fibers, and also dendrites from the deeper laminae of dorsal horns of the spinal cord. This permits to suggest that gelatinous substance acts as the spinal gate, modulating conduction of nerve impulses from peripheral receptors to the neurons of the spinal cord that project to the brain, relay neurons. Gate control theory. The gate control theory of pain asserts that non-painful input closes the nerve gates to painful input, which prevents pain sensation from traveling to the central nervous system. The gate control theory of pain describes how non-painful sensations can override and reduce painful sensations. A painful, nociceptive stimulus stimulates primary afferent fibers and travels to the brain via transmission cells. Increasing activity of the transmission cells results in increased perceived pain. Conversely, decreasing activity of transmission cells reduces perceived pain. In the gate control theory, a closed gate describes when input to transmission cells is blocked, therefore reducing the sensation of pain. An open gate describes when input to transmission cells is permitted, therefore allowing the sensation of pain. In the top panel, the non-nociceptive, large diameter sensory fiber, orange, is more active than the nociceptive small diameter fiber, blue. Therefore the net input to the inhibitory interneuron, red, is net positive. The inhibitory interneuron provides presynaptic inhibition to both the nociceptive and non-nociceptive neurons, reducing the excitation of the transmission cells. In the bottom panel, an open gate, free-flowing information from afferents to the transmission cells, is pictured. This occurs when there is more activity in the nociceptive small-diameter fibers, blue, than the non-nociceptive large-diameter fibers, orange. In this situation, the inhibitory interneuron is silenced, which relieves inhibition of the transmission cells. This open gate allows for transmission cells to be excited, and thus pain to be sensed. First proposed in 1965 by Ronald Meltsack and Patrick Wall, the theory offers a physiological explanation for the previously observed effect of psychology on pain perception. Combining early concepts derived from the specificity theory and the peripheral pattern theory, the gate control theory is considered to be one of the most influential theories of pain. This theory provided a neural basis which reconciled the specificity and pattern theories and ultimately revolutionized pain research. Although there are some important observations that the gate control theory cannot explain adequately, this theory remains the theory of pain which most accurately accounts for the physical and psychological aspects of pain perception. Willem Noordenbos, 1910–1990, a Dutch researcher at the University of Amsterdam, proposed in 1959 a model which featured interaction between small, unmyelinated, and thick, myelinated, fibers. In this model, the fast, myelinated, fibers block the slow, unmyelinated, fibers, fast blocks slow. Proposed mechanisms. When you experience a negative feeling, such as pain from a bump or an itch from a bug bite, a common reaction is an attempt to eliminate the feeling by rubbing the painful bump or scratching the itchy bite. Gate control theory asserts that activation of nerves that do not transmit pain signals, called non-nociceptive fibers, can interfere with signals from pain fibers, thereby inhibiting pain. It is proposed that both small diameter, pain transmitting, and large diameter, touch dash, pressure dash, and vibration transmitting, afferent nerve fibers carry information from the site of the injury to two destinations in the dorsal horn. One transmission cells that carry the pain signal up to the brain. And two inhibitory interneurons that impede transmission cell activity. Activation of transmission cells occurs from both excitatory small diameter and excitatory large diameter fibers. However, activation of the inhibitory interneurons varies. Large diameter fibers excite the interneuron, which ultimately reduces transmission cell firing citation needed, whereas small diameter fibers inhibit the inhibitory interneuron, which lessens the inhibitory input to the transmission cell. Therefore, less pain is felt, via reduced transmission cell activity, when more activity in large diameter fibers, touch dash, pressure dash, and vibration transmitting, occurs relative to the activity in small diameter, pain transmitting, fibers. The peripheral nervous system has centers at which pain stimuli can be regulated. Some areas in the dorsal horn of the spinal cord that are involved in receiving pain stimuli from A delta and C fibers, called laminae, also receive input from A beta fibers. The non-nociceptive fibers indirectly inhibit the effects of the pain fibers, closing a gate to the transmission of their stimuli. In other parts of the laminae, pain fibers also inhibit the effects of non-nociceptive fibers, opening the gate. This presynaptic inhibition of the dorsal nerve endings can occur through specific types of GABA receptors, not through the alpha-1 GABA receptor and not through the activation of glycine receptors, which are also absent from these types of terminals. Thus, certain GABA receptor subtypes but not glycine receptors can presynaptically regulate nociception and pain transmission. An inhibitory connection may exist with A beta and C fibers, which may form a synapse on the same projection neuron. The same neurons may also form synapses with an inhibitory interneuron that also synapses on the projection neuron, reducing the chance that the latter will fire and transmit pain stimuli to the brain, image on the right. The inhibitory interneuron fires spontaneously. The C fibers synapse would inhibit the inhibitory interneuron, indirectly increasing the projection neuron's chance of firing. The A beta fiber, on the other hand, forms an excitatory connection with the inhibitory interneuron, thus decreasing the projection neuron's chance of firing. Like the C fiber, the A beta fiber also has an excitatory connection on the projection neuron itself. Thus, depending on the relative rates of firing of C and A beta fibers. The firing of the non-nociceptive fiber may inhibit the firing of the projection neuron and the transmission of pain stimuli. Gate control theory is very popular. On the internet you can find many variants of circuits, but the essence of this theory does not change. There is such a scheme. 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 But you better stick to the classic scheme. By the way, what are these synapses called? Are these synapses excitatory or inhibitory? These are axo-axonal synapses. They always break. Pain receptors and their stimulation. Painful stimulations may arise from skin, deep tissues, and internal organs. These stimulations are perceived by receptors, nociceptors, located throughout the body excluding the brain. Methods of microneurography confirmed the existence in humans and other mammalians of two types of pain receptors. The first type of these receptors is anatomically represented by free nerve endings that branch out in a tree-like manner, myelinated fibers. These are fast A-delta fibers conducting excitation at 6 to 30 m/s. These fibers are excited by high-intensity mechanical, a prick of a needle, and sometimes by thermal stimulations of skin. A-delta nociceptors are primarily located in skin. Besides, they are also found in joints. The other type of nociceptors is represented by dense non-capsulated glomerular bodies, unmyelinated C fibers conducting excitation at 0.5 to 2 m/s. In humans and other primates, these afferent fibers are represented by polymodal nociceptors that respond to mechanical, as well as thermal and chemical stimuli. They are activated by chemical substances produced in tissue damage, and at the same time act as chemoreceptors. C fibers are distributed throughout all tissues excluding the CNS. However, they are present in peripheral nerves as nervi nervorum. Fibers having receptors perceiving tissue damages contain substance P which acts as a neurotransmitter. All types of nociceptors are characterized by low excitability. Bioactive substances that stimulate chemonociceptors are called algogens. There are three groups of algogens: tissue algogens, plasma algogens, and algogens released from the nerve endings. Tissue algogens are serotonin, histamine, some prostaglandins and high concentrations of K and H andions. Plasma algogens include bradykinin, calladin, and Hageman's contact factor. The third group includes an oligopeptide, substance P. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Write the answer in the general chat of the BBB. What is A-alpha? A-delta, B, and C fibers? From what classification? What is A-alpha? A-delta, B, and C fibers? From what classification? The axons of neurons in the human peripheral nervous system can be classified based on their physical features and signal conduction properties. Axons were known to have different thicknesses, from 0.1 to 20 m, and these differences were thought to relate to the speed at which an action potential could travel along the axon, its conductance velocity. Erlanger and Gasser proved this hypothesis, and identified several types of nerve fiber, establishing a relationship between the diameter of an axon and its nerve conduction velocity. They published their findings in 1941, giving the first classification of axons. Axons are classified in two systems. The first one, introduced by Erlanger and Gasser, grouped the fibers into three main groups using the letters A, B, and C. These groups, Group A, Group B, and Group C, include both the sensory fibers, afferents, and the motor fibers, efferents. The first Group A was subdivided into alpha, beta, gamma, and delta fibers, A alpha, A beta, A gamma, and A delta. The motor neurons of the different motor fibers were the lower motor neurons, alpha motor neuron, beta motor neuron, and gamma motor neuron having the A alpha, A beta, and A gamma nerve fibers, respectively. Later findings by other researchers identified two groups of AA fibers that were sensory fibers. These were then introduced into a system that only included sensory fibers, though some of these were mixed nerves and were also motor fibers. This system refers to the sensory groups as types and uses Roman numerals, type IA, type IB, type 2, type 3, and type 4. Let's repeat it again. Erlanger and Gasser grouped the fibers into three main groups using the letters A, B, and C. These groups, Group A, Group B, and Group C include both the sensory fibers, afferents, and the motor fibers, efferents. The first Group A was subdivided into alpha, beta, gamma, and delta fibers, A alpha, A beta, A gamma, and A delta. The motor neurons of the different motor fibers were the lower motor neurons, alpha motor neuron, beta motor neuron, and gamma motor neuron having the A alpha, A beta, and A gamma nerve fibers, respectively. And now, you have to answer the question and write in the chat. I will look and note in the electronic journal who is present at the lecture. If there is no answer, then I will post absence. Write the answer in the general chat of the BBB. Pain receptors and their stimulation. Pain receptors are free nerve endings. The pain receptors in the skin and other tissues are all free nerve endings. They are widespread in the superficial layers of the skin as well as in certain internal tissues, such as the periosteum, the arterial walls, the joint surfaces, and the falx and tentorium in the cranial vault. Most other deep tissues are only sparsely supplied with pain endings. Nevertheless, any widespread tissue damage can summit to cause the slow chronic aching type of pain in most of these areas. Three types of stimuli excite pain receptors: mechanical, thermal, and chemical. Pain can be elicited by multiple types of stimuli. They are classified as mechanical, thermal, and chemical pain stimuli. In general, fast pain is elicited by the mechanical and thermal types of stimuli, whereas slow pain can be elicited by all three types. Some of the chemicals that excite the chemical type of pain are bradykinin, serotonin, histamine, potassium ions, acids, acetylcholine, and proteolytic enzymes. In addition, prostaglandins and substance P enhance the sensitivity of pain endings but do not directly excite them. The chemical substances are especially important in stimulating the slow, suffering type of pain that occurs after tissue injury. Non-adapting nature of pain receptors. In contrast to most other sensory receptors of the body, pain receptors adapt very little and sometimes not at all. In fact, under some conditions, excitation of pain fibers becomes progressively greater, especially so for slow aching nauseous pain, as the pain stimulus continues. This increase in sensitivity of the pain receptors is called hyperalgesia. One can readily understand the importance of this failure of pain receptors to adapt, because it allows the pain to keep the person apprised of a tissue-damaging stimulus as long as it persists. Rate of tissue damage as a stimulus for pain. The average person begins to perceive pain when the skin is heated above 45 degrees Celsius, as shown in figure. This is also the temperature at which the tissues begin to be damaged by heat. Indeed, the tissues are eventually destroyed if the temperature remains above this level indefinitely. Therefore, it is immediately apparent that pain resulting from heat is closely correlated with the rate at which damage to the tissues is occurring and not with the total damage that has already occurred. The intensity of pain is also closely correlated with the rate of tissue damage from causes other than heat, such as bacterial infection, tissue ischemia, tissue contusion, and so forth. Figure. Distribution curve obtained from a large number of persons showing the minimal skin temperature that will cause pain. Special importance of chemical pain stimuli during tissue damage. Extracts from damaged tissue cause intense pain when injected beneath the normal skin. Most of the chemicals listed earlier that excite the chemical pain receptors can be found in these extracts. One chemical that seems to be more painful than others is bradykinin. Many researchers have suggested that bradykinin might be the agent most responsible for causing pain following tissue damage. Also, the intensity of the pain felt correlates with the local increase in potassium ion concentration or the increase in proteolytic enzymes that directly attack the nerve endings and excite pain by making the nerve membranes more permeable to ions. Tissue ischemia is a cause of pain. When blood flow to a tissue is blocked, the tissue often becomes very painful within a few minutes. The greater the rate of metabolism of the tissue, the more rapidly the pain appears. For instance, if a blood pressure cuff is placed around the upper arm and inflated until the arterial blood flow ceases, exercise of the forearm muscles sometimes can cause muscle pain within 15 to 20 seconds. In the absence of muscle exercise, the pain may not appear for 3 to 4 minutes even though the muscle blood flow remains zero. One of the suggested causes of pain during ischemia is accumulation of large amounts of lactic acid in the tissues, formed as a consequence of anaerobic metabolism, metabolism without oxygen. It is also probable that other chemical agents, such as bradykinin and proteolytic enzymes, are formed in the tissues because of cell damage and that these, in addition to lactic acid, stimulate the pain nerve endings. Muscle spasm is a cause of pain. Muscle spasm is also a common cause of pain, and it is the basis of many clinical pain syndromes. This pain probably results partially from the direct effect of muscle spasm in stimulating mechanosensitive pain receptors, but it might also result from the indirect effect of muscle spasm to compress the blood vessels and cause ischemia. Also, the spasm increases the rate of metabolism in the muscle tissue, thus making the relative ischemia even greater, creating ideal conditions for the release of chemical pain-inducing substances. Dual pathways for transmission of pain signals into the central nervous system. Dual pathways for transmission of pain signals into the central nervous system. Even though all pain receptors are free nerve endings, these endings use two separate pathways for transmitting pain signals into the central nervous system. The two pathways mainly correspond to the two types of pain: a fast sharp pain pathway and a slow chronic pain pathway. Peripheral pain fibers: fast and slow fibers. The fast sharp pain signals are elicited by either mechanical or thermal pain stimuli. They are transmitted in the peripheral nerves to the spinal cord by small type A delta fibers at velocities between 6 and 30 m/section. Conversely, the slow chronic type of pain is elicited mostly by chemical types of pain stimuli but sometimes by persisting mechanical or thermal stimuli. This slow chronic pain is transmitted to the spinal cord by type C fibers at velocities between 0.5 and 2 m/section. Because of this double system of pain innervation, a sudden painful stimulus often gives a double pain sensation, a fast sharp pain that is transmitted to the brain by the A delta fiber pathway, followed a second or so later by a slow pain that is transmitted by the C fiber pathway. The sharp pain arises the person rapidly of a damaging influence and, therefore, plays an important role in making the person react immediately to remove himself or herself from the stimulus. The slow pain tends to become greater over time. This sensation eventually produces the intolerable suffering of long-continued pain and makes the person keep trying to relieve the cause of the pain. Peripheral pain fibers: fast and slow fibers. On entering the spinal cord from the dorsal spinal roots, the pain fibers terminate on relay neurons in the dorsal horns. Here again, there are two systems for processing the pain signals on their way to the brain, as shown in figures. Figure: transmission of both fast sharp and slow chronic pain signals into and through the spinal cord on their way to the brain. Figure: transmission of pain signals into the brain stem, thalamus, and cerebral cortex by way of the fast pricking pain pathway and the slow burning pain pathway. Dual pain pathways in the cord and brain stem: the neospinothalamic tract and the paleospinothalamic tract. On entering the spinal cord, the pain signals take two pathways to the brain, through 1. the neospinothalamic tract and 2. the paleospinothalamic tract. Neospinothalamic tract for fast pain. The fast type A delta pain fibers transmit mainly mechanical and acute thermal pain. They terminate mainly in lamina I, lamina marginalis, of the dorsal horns, as shown in figure, and there excite second-order neurons of the neospinothalamic tract. These give rise to long fibers that cross immediately to the opposite side of the cord through the anterior commissure and then turn upward, passing to the brain in the anterolateral columns. Figure: transmission of both fast sharp and slow chronic pain signals into and through the spinal cord on their way to the brain. Termination of the neospinothalamic tract in the brain stem and thalamus. A few fibers of the neospinothalamic tract terminate in the reticular areas of the brain stem, but most pass all the way to the thalamus without interruption, terminating in the ventrobasal complex along with the dorsal column, medial lemniscal tract for tactile sensations. A few fibers also terminate in the posterior nuclear group of the thalamus. From these thalamic areas, the signals are transmitted to other basal areas of the brain as well as to the somatosensory cortex. Capability of the nervous system to localize fast pain in the body. The fast sharp type of pain can be localized much more exactly in the different parts of the body than can slow chronic pain. However, when only pain receptors are stimulated, without the simultaneous stimulation of tactile receptors, even fast pain may be poorly localized, often only within 10 centimeters or so of the stimulated area. Yet when tactile receptors that excite the dorsal column, medial lemniscal system are simultaneously stimulated, the localization can be nearly exact. Glutamate, the probable neurotransmitter of the type A delta fast pain fibers. It is believed that glutamate is the neurotransmitter substance secreted in the spinal cord at the type A delta pain nerve fiber endings. This is one of the most widely used excitatory transmitters in the central nervous system, usually having a duration of action lasting for only a few milliseconds. Palliaspinothalamic pathway for transmitting slow chronic pain. The palliaspinothalamic pathway is a much older system and transmits pain mainly from the peripheral slow chronic type C pain fibers, although it does transmit some signals from type A delta fibers as well. In this pathway, the peripheral fibers terminate in the spinal cord almost entirely in laminae 2 and 3 of the dorsal horns, which together are called the substantia gelatinosa, as shown by the lateral-most dorsal root type C fiber in figure. Most of the signals then pass through one or more additional short fiber neurons within the dorsal horns themselves before entering mainly lamina V, also in the dorsal horn. Here the last neurons in the series give rise to long axons that mostly join the fibers from the fast pain pathway, passing first through the anterior commissure to the opposite side of the cord, then upward to the brain in the anterolateral pathway. Substance P, the probable slow chronic neurotransmitter of type C nerve endings. Research experiments suggest that type C pain fiber terminals entering the spinal cord secrete both glutamate transmitter and substance P transmitter. The glutamate transmitter acts instantaneously and lasts for only a few milliseconds. Substance P is released much more slowly, building up in concentration over a period of seconds or even minutes. In fact, it has been suggested that the double pain sensation one feels after a pinprick might result partly from the fact that the glutamate transmitter gives a faster pain sensation, whereas the substance P transmitter gives a more lagging sensation. Regardless of the yet unknown details, it seems clear that glutamate is the neurotransmitter most involved in transmitting fast pain into the central nervous system, and substance P is concerned with slow chronic pain. Projection of the palliaspinothalamic pathway, slow chronic pain signals, into the brain stem and thalamus. The slow chronic palliaspinothalamic pathway terminates widely in the brain stem, in the large shaded area shown in figure. Only 1/10 to 1/4 of the fibers pass all the way to the thalamus. Instead, most terminate in one of three areas: 1. The reticular nuclei of the medulla, pons, and mesencephalon; 2. The tectal area of the mesencephalon deep to the superior and inferior colliculi; or 3. The periaqueductal gray region surrounding the aqueduct of Sylvius. These lower regions of the brain appear to be important for feeling the suffering types of pain, because animals whose brains have been sectioned above the mesencephalon to block pain signals from reaching the cerebrum still evince undeniable evidence of suffering when any part of the body is traumatized. From the brain stem pain areas, multiple short fiber neurons relay the pain signals upward into the intralaminar and ventrolateral nuclei of the thalamus and into certain portions of the hypothalamus and other basal regions of the brain. Very poor capability of the nervous system to localize precisely the source of pain transmitted in the slow chronic pathway. Localization of pain transmitted by way of the palliaspinothalamic pathway is poor. For instance, slow chronic pain can usually be localized only to a major part of the body, such as to one arm or leg, but not to a specific point on the arm or leg. This is in keeping with the multisynaptic, diffuse connectivity of this pathway. It explains why patients often have serious difficulty in localizing the source of some chronic types of pain. Function of the reticular formation, thalamus, and cerebral cortex in the appreciation of pain. Complete removal of the somatic sensory areas of the cerebral cortex does not destroy an animal's ability to perceive pain. Therefore, It is likely that pain impulses entering the brainstem reticular formation, the thalamus, and other lower brain centers cause conscious perception of pain. This does not mean that the cerebral cortex has nothing to do with normal pain appreciation. Electrical stimulation of cortical somatosensory areas does cause a human being to perceive mild pain from about 3% of the points stimulated. However, it is believed that the cortex plays an especially important role in interpreting pain quality, even though pain perception might be principally the function of lower centers. Special capability of pain signals to arouse overall brain excitability. Electrical stimulation in the reticular areas of the brainstem and in the intralaminar nuclei of the thalamus, the areas where the slow-suffering type of pain terminates, has a strong arousal effect on nervous activity throughout the entire brain. In fact, these two areas constitute part of the brain's principal arousal system. This explains why it is almost impossible for a person to sleep when he or she is in severe pain. Surgical interruption of pain pathways. When a person has severe and intractable pain, sometimes resulting from rapidly spreading cancer, it is necessary to relieve the pain. To do this, the pain nervous pathways can be cut at any one of several points. If the pain is in the lower part of the body, a cordotomy in the thoracic region of the spinal cord often relieves the pain for a few weeks to a few months. To do this, the spinal cord on the side opposite to the pain is partially cut in its anterolateral quadrant to interrupt the anterolateral sensory pathway. A cordotomy, however, is not always successful in relieving pain, for two reasons. First, many pain fibers from the upper part of the body do not cross to the opposite side of the spinal cord until they have reached the brain, so that the cordotomy does not transect these fibers. Second, pain frequently returns several months later, partly as a result of sensitization of other pathways that normally are too weak to be effectual, example sparse pathways in the dorsolateral cord. Another experimental operative procedure to relieve pain has been to cauterize specific pain areas in the intralaminar nuclei in the thalamus, which often relieves suffering types of pain while leaving intact one's appreciation of acute pain, an important protective mechanism. Pain suppression, analgesia, system in the brain and spinal cord. Pain suppression, analgesia, system in the brain and spinal cord. The degree to which a person reacts to pain varies tremendously. This results partly from a capability of the brain itself to suppress input of pain signals to the nervous system by activating a pain control system, called an analgesia system. The analgesia system is shown in figure. Analgesia system of the brain and spinal cord, showing inhibition of incoming pain signals at the cord level and 2. Presence of enkephalin-secreting neurons that suppress pain signals in both the cord and the brain stem. It consists of three major components. 1. The periaqueductal gray and periventricular areas of the mesencephalon and upper pons surround the aqueduct of Sylvius and portions of the third and fourth ventricles. Neurons from these areas send signals to 2. The raphe magnus nucleus, a thin midline nucleus located in the lower pons and upper medulla, and the nucleus reticularis perigigantocellularis, located laterally in the medulla. From these nuclei, second-order signals are transmitted down the dorsolateral columns in the spinal cord to 3. A pain inhibitory complex located in the dorsal horns of the spinal cord. At this point, the analgesia signals can block the pain before it is relayed to the brain. Electrical stimulation either in the periaqueductal gray area or in the raphe magnus nucleus can suppress many strong pain signals entering by way of the dorsal spinal roots. Also, stimulation of areas at still higher levels of the brain that excite the periaqueductal gray area can also suppress pain. Some of these areas are 1. The periventricular nuclei in the hypothalamus, lying adjacent to the third ventricle, and 2. To a lesser extent, the medial forebrain bundle, also in the hypothalamus. Several transmitter substances are involved in the analgesia system, especially involved are enkephalin and serotonin. Many nerve fibers derived from the periventricular nuclei and from the periaqueductal gray area secrete enkephalin at their endings. Thus, as shown in figure, the endings of many fibers in the raphe magnus nucleus release enkephalin when stimulated. Fibers originating in this area send signals to the dorsal horns of the spinal cord to secrete serotonin at their endings. The serotonin causes local cord neurons to secrete enkephalin as well. The enkephalin is believed to cause both presynaptic and postsynaptic inhibition of incoming type C and type A delta pain fibers where they synapse in the dorsal horns. Thus, the analgesia system can block pain signals at the initial entry point to the spinal cord. In fact, it can also block many local cord reflexes that result from pain signals. Brain's opiate system: endorphins and enkephalins. The injection of minute quantities of morphine either into the periventricular nucleus around the third ventricle or into the periaqueductal gray area of the brain stem causes an extreme degree of analgesia. In subsequent studies, it has been found that morphine-like agents, mainly the opiates, also act at many other points in the analgesia system, including the dorsal horns of the spinal cord. Because most drugs that alter excitability of neurons do so by acting on synaptic receptors, it was assumed that the morphine receptors of the analgesia system must be receptors for some morphine-like neurotransmitter that is naturally secreted in the brain. The two enkephalins are found in the brain stem and spinal cord, in the portions of the analgesia system described earlier, and beta-endorphin is present in both the hypothalamus and the pituitary gland. Dynorphin is found mainly in the same areas as the enkephalins but in much lower quantities. Thus, although the fine details of the brain's opiate system are not understood, activation of the analgesia system by nervous signals entering the periaqueductal gray and periventricular areas, or inactivation of pain pathways by morphine-like drugs, can almost totally suppress many pain signals entering through the peripheral nerves.
I'd like some ketamine for my appetizer. What opiate would you recommend for my entree?
Inhibition of pain transmission by simultaneous tactile sensory signals. Inhibition of pain transmission by simultaneous tactile sensory signals. Another important event in the saga of pain control was the discovery that stimulation of large type A beta sensory fibers from peripheral tactile receptors can depress transmission of pain signals from the same body area. This presumably results from local lateral inhibition in the spinal cord. It explains why such simple maneuvers as rubbing the skin near painful areas is often effective in relieving pain. And it probably also explains why liniments are often useful for pain relief.
I don't feel like rubbing your back. Set your phone to vibrate. Place it on your back and I'll call you.
Inhibition of pain transmission by simultaneous tactile sensory signals. This mechanism and the simultaneous psychogenic excitation of the central analgesia system are probably also the basis of pain relief by acupuncture. Acupuncture is a form of alternative medicine and a component of traditional Chinese medicine, TCM, in which thin needles are inserted into the body. There is a range of acupuncture variants which originated in different philosophies, and techniques vary depending on the country in which it is performed, but can be divided into two main foundational philosophical applications and approaches. The first being the modern standardized form called 8 Principles TCM, and the second an older system that is based on the ancient Daoist Wuxing, better known as the 5 elements or phases in the West. Acupuncture is most often used to attempt pain relief, though acupuncturists say that it can also be used for a wide range of other conditions. Acupuncture is generally used only in combination with other forms of treatment. The conclusions of trials and systematic reviews of acupuncture generally provide no good evidence of benefit, which suggests that it is not an effective method of healthcare. Acupuncture is a pseudoscience. The theories and practices of TCM are not based on scientific knowledge, and it has been characterized as quackery. Acupuncture options from mammoths to the present day. It's a joke. Treatment of pain by electrical stimulation. Treatment of pain by electrical stimulation. Several clinical procedures have been developed for suppressing pain by electrical stimulation. Stimulating electrodes are placed on selected areas of the skin or, on occasion, implanted over the spinal cord, supposedly to stimulate the dorsal sensory columns. In some patients, electrodes have been placed stereotaxically in appropriate intralaminar nuclei of the thalamus or in the periventricular or periaqueductal area of the diencephalon. The patient can then personally control the degree of stimulation. Dramatic relief has been reported in some instances. Also, pain relief has been reported to last for as long as 24 hours after only a few minutes of stimulation. Referred pain. Referred pain. Often a person feels pain in a part of the body that is fairly remote from the tissue causing the pain. This is called referred pain. For instance, pain in one of the visceral organs often is referred to an area on the body surface. Knowledge of the different types of referred pain is important in clinical diagnosis because in many visceral ailments the only clinical sign is referred pain. Mechanism of referred pain. Figure shows the probable mechanism by which most pain is referred. In the figure, branches of visceral pain fibers are shown to synapse in the spinal cord on the same second-order neurons, 1 and 2, that receive pain signals from the skin. When the visceral pain fibers are stimulated, pain signals from the viscera are conducted through at least some of the same neurons that conduct pain signals from the skin, and the person has the feeling that the sensations originate in the skin itself. Figure. Mechanism of referred pain and referred hyperalgesia. Note. We have modified figure 48 to 5 from Guyton's textbook on page 603. The identical figure in the lecture shows branches of visceral pain fibers that form synapses in the spinal cord on the same second-order neurons, 1 and 2, that receive pain signals from the skin, i.e. converge. Visceral pain. In clinical diagnosis, pain from the different viscera of the abdomen and chest is one of the few criteria that can be used for diagnosing visceral inflammation, visceral infectious disease, and other visceral ailments. Often, the viscera have sensory receptors for no other modalities of sensation besides pain. Also, visceral pain differs from surface pain in several important aspects. One of the most important differences between surface pain and visceral pain is that highly localized types of damage to the viscera seldom cause severe pain. For instance, a surgeon can cut the gut entirely in two in a patient who is awake without causing significant pain. Conversely, any stimulus that causes diffuse stimulation of pain nerve endings throughout a viscus causes pain that can be severe. For instance, ischemia caused by occluding the blood supply to a large area of gut stimulates many diffuse pain fibers at the same time and can result in extreme pain. Causes of true visceral pain. Any stimulus that excites pain nerve endings in diffuse areas of the viscera can cause visceral pain. Such stimuli include ischemia of visceral tissue, chemical damage to the surfaces of the viscera, spasm of the smooth muscle of a hollow viscus, excess distension of a hollow viscus, and stretching of the connective tissue surrounding or within the viscus. Essentially all visceral pain that originates in the thoracic and abdominal cavities is transmitted through small type C pain fibers and, therefore, can transmit only the chronic aching suffering type of pain. Ischemia. Ischemia causes visceral pain in the same way that it does in other tissues, presumably because of the formation of acidic metabolic end products or tissue degenerative products such as bradykinin, proteolytic enzymes, or others that stimulate pain nerve endings. Chemical stimuli. On occasion, damaging substances leak from the gastrointestinal tract into the peritoneal cavity. For instance, proteolytic acidic gastric juice often leaks through a ruptured gastric or duodenal ulcer. This juice causes widespread digestion of the visceral peritoneum, thus stimulating broad areas of pain fibers. The pain is usually excruciatingly severe. Spasm of a hollow viscus. Spasm of a portion of the gut, the gallbladder, a bile duct, a ureter, or any other hollow viscus can cause pain, possibly by mechanical stimulation of the pain nerve endings. Or the spasm might cause diminished blood flow to the muscle, combined with the muscle's increased metabolic need for nutrients, thus causing severe pain. Often pain from a spastic viscus occurs in the form of cramps, with the pain increasing to a high degree of severity and then subsiding. This process continues intermittently, once every few minutes. The intermittent cycles result from periods of contraction of smooth muscle. For instance, each time a peristaltic wave travels along an overly excitable spastic gut, a cramp occurs. The cramping type of pain frequently occurs in appendicitis, gastroenteritis, constipation, menstruation, parturition, gallbladder disease, or ureteral obstruction. Overdistension of a hollow viscus. Extreme overfilling of a hollow viscus also can result in pain, presumably because of overstretch of the tissues themselves. Overdistension can also collapse the blood vessels that encircle the viscus or that pass into its wall, thus perhaps promoting ischemic pain. Insensitive viscera. A few visceral areas are almost completely insensitive to pain of any type. These include the parenchyma of the liver and the alveoli of the lungs. Yet the liver capsule is extremely sensitive to both direct trauma and stretch, and the bile ducts are also sensitive to pain. In the lungs, even though the alveoli are insensitive, Both the bronchi and the parietal pleura are very sensitive to pain. Localization of visceral pain. Visceral and the parietal pain transmission pathways. Localization of visceral pain. Visceral and the parietal pain transmission pathways. Pain from the different viscera is frequently difficult to localize, for a number of reasons. First, the patient's brain does not know from first-hand experience that the different internal organs exist, therefore, any pain that originates internally can be localized only generally. Second, sensations from the abdomen and thorax are transmitted through two pathways to the central nervous system: the true visceral pathway and the parietal pathway. True visceral pain is transmitted via pain sensory fibers within the autonomic nerve bundles, and the sensations are referred to surface areas of the body often far from the painful organ. Conversely, parietal sensations are conducted directly into local spinal nerves from the parietal peritoneum, pleura, or pericardium, and these sensations are usually localized directly over the painful area. Localization of referred pain transmitted via visceral pathways. When visceral pain is referred to the surface of the body, the person generally localizes it in the dermatomal segment from which the visceral organ originated in the embryo, not necessarily where the visceral organ now lies. For instance, the heart originated in the neck and upper thorax, so that the heart's visceral pain fibers pass upward along the sympathetic sensory nerves and enter the spinal cord between segments C3 and T5. Therefore, as shown in figure, pain from the heart is referred to the side of the neck, over the shoulder, over the pectoral muscles, down the arm, and into the substernal area of the upper chest. These are the areas of the body surface that send their own somatosensory nerve fibers into the C3 to T5 cord segments. Most frequently, the pain is on the left side rather than on the right because the left side of the heart is much more frequently involved in coronary disease than the right. The stomach originated approximately from the 7th to 9th thoracic segments of the embryo. Therefore, stomach pain is referred to the anterior epigastrium above the umbilicus, which is the surface area of the body subserved by the 7th through 9th thoracic segments. Figure shows several other surface areas to which visceral pain is referred from other organs, representing in general the areas in the embryo from which the respective organs originated. Figure. Surface areas of referred pain from different visceral organs. Parietal pathway for transmission of abdominal and thoracic pain. Pain from the viscera is frequently localized to two surface areas of the body at the same time because of the dual transmission of pain through the referred visceral pathway and the direct parietal pathway. Thus, figure shows dual transmission from an inflamed appendix. Pain impulses pass first from the appendix through visceral pain fibers located within sympathetic nerve bundles, and then into the spinal cord at about T10 or T11. This pain is referred to an area around the umbilicus and is of the aching, cramping type. Pain impulses also often originate in the parietal peritoneum where the inflamed appendix touches or is adherent to the abdominal wall. These cause pain of the sharp type directly over the irritated peritoneum in the right lower quadrant of the abdomen. Figure. Visceral and parietal transmission of pain signals from the appendix. Some clinical abnormalities of pain and other somatic sensations. Some clinical abnormalities of pain and other somatic sensations. Hyperalgesia. A pain nervous pathway sometimes becomes excessively excitable. This gives rise to hyperalgesia, which means hypersensitivity to pain. Possible causes of hyperalgesia are 1. Excessive sensitivity of the pain receptors themselves, which is called primary hyperalgesia, and 2. Facilitation of sensory transmission, which is called secondary hyperalgesia. An example of primary hyperalgesia is the extreme sensitivity of sunburned skin, which results from sensitization of the skin pain endings by local tissue products from the burn, perhaps histamine, perhaps prostaglandins, perhaps others. Secondary hyperalgesia frequently results from lesions in the spinal cord or the thalamus. Several of these lesions are discussed in subsequent sections. Herpes zoster, shingles. Occasionally herpes virus infects a dorsal root ganglion. This causes severe pain in the dermatomal segment subserved by the ganglion, thus eliciting a segmental type of pain that circles halfway around the body. The disease is called herpes zoster, or shingles, because of a skin eruption that often ensues. The cause of the pain is presumably infection of the pain neuronal cells in the dorsal root ganglion by the virus. In addition to causing pain, the virus is carried by neuronal cytoplasmic flow outward through the neuronal peripheral axons to their cutaneous origins. Here the virus causes a rash that vesiculates within a few days and then crusts over within another few days, all of this occurring within the dermatomal area served by the infected dorsal root. Here's a prescription for your shingles. Side effects include punching people who ask why you didn't get brick or siding instead. Tic douloureux. Lancinating pain occasionally occurs in some people over one side of the face in the sensory distribution area, or part of the area, of the fifth or ninth nerves. This phenomenon is called tic douloureux, or trigeminal neuralgia or glossopharyngeal neuralgia. The pain feels like sudden electrical shocks, and it may appear for only a few seconds at a time or may be almost continuous. Often it is set off by exceedingly sensitive trigger areas on the surface of the face, in the mouth, or inside the throat, almost always by a mechanoreceptive stimulus rather than a pain stimulus. For instance, when the patient swallows a bolus of food, as the food touches a tonsil, it might set off a severe lancinating pain in the mandibular portion of the fifth nerve. The pain of tic douloureux can usually be blocked by surgically cutting the peripheral nerve from the hypersensitive area. The sensory portion of the fifth nerve is often sectioned immediately inside the cranium, where the motor and sensory roots of the fifth nerve separate from each other, so that the motor portions, which are needed for many jaw movements, can be spared while the sensory elements are destroyed. This operation leaves the side of the face anesthetic, which in itself may be annoying. Furthermore, sometimes the operation is unsuccessful, indicating that the lesion that causes the pain might be in the sensory nucleus in the brain stem and not in the peripheral nerves. Brown-Séquard syndrome. If the spinal cord is transected entirely, all sensations and motor functions distal to the segment of transection are blocked, but if the spinal cord is transected on only one side, the Brown-Séquard syndrome occurs. The effects of such transection can be predicted from a knowledge of the cord fiber tracts shown in figure. Cross-section of the spinal cord, showing principal ascending tracts on the right and principal descending tracts on the left. All motor functions are blocked on the side of the transection in all segments below the level of the transection. Yet only some of the modalities of sensation are lost on the transected side, and others are lost on the opposite side. The sensations of pain, heat, and cold sensations served by the spinothalamic pathway are lost on the opposite side of the body in all dermatomes 2 to 6 segments below the level of the transection. By contrast, the sensations that are transmitted only in the dorsal and dorsolateral columns, kinesthetic and position sensations, vibration sensation, discrete localization, and two-point discrimination, are lost on the side of the transection in all dermatomes below the level of the transection. Discrete light touch is impaired on the side of the transection because the principal pathway for the transmission of light touch, the dorsal column, is transected. That is, the fibers in this column do not cross to the opposite side until they reach the medulla of the brain. Crude touch, which is poorly localized, still persists because of partial transmission in the opposite spinothalamic tract. Headache. Headache. Headaches are a type of pain referred to the surface of the head from deep head structures. Some headaches result from pain stimuli arising inside the cranium, but others result from pain arising outside the cranium, such as from the nasal sinuses. Will you go out with me this Saturday?
Sorry, I'm having a headache this weekend.
Headache. Headache of intracranial origin. Pain-sensitive areas in cranial vault. The brain tissues themselves are almost totally insensitive to pain. Even cutting or electrically stimulating the sensory areas of the cerebral cortex only occasionally causes pain. Instead, it causes prickly types of paresthesias on the area of the body represented by the portion of the sensory cortex stimulated. Therefore, it is likely that much or most of the pain of headache is not caused by damage within the brain itself. Conversely, tugging on the venous sinuses around the brain, damaging the tentorium, or stretching the dura at the base of the brain can cause intense pain that is recognized as headache. Also, almost any type of traumatizing, crushing, or stretching stimulus to the blood vessels of the meninges can cause headache. An especially sensitive structure is the middle meningeal artery, and neurosurgeons are careful to anesthetize this artery specifically when performing brain operations under local anesthesia. Areas of the head to which intracranial headache is referred. Stimulation of pain receptors in the cerebral vault above the tentorium, including the upper surface of the tentorium itself, initiates pain impulses in the cerebral portion of the fifth nerve and, therefore, causes referred headache to the front half of the head in the surface areas supplied by this somatosensory portion of the fifth cranial nerve, as shown in figure. Conversely, pain impulses from beneath the tentorium enter the central nervous system mainly through the glossopharyngeal, vagal, and second cervical nerves, which also supply the scalp above, behind, and slightly below the ear. Subtentorial pain stimuli cause occipital headache, referred to the posterior part of the head. Figure. Areas of headache resulting from different causes. Types of intracranial headache. Headache of meningitis. One of the most severe headaches of all is that resulting from meningitis, which causes inflammation of all the meninges, including the sensitive areas of the dura and the sensitive areas around the venous sinuses. Such intense damage can cause extreme headache pain referred over the entire head. Headache caused by low cerebrospinal fluid pressure. Removing as little as 20 milliliters of fluid from the spinal canal, particularly if the person remains in an upright position, often causes intense intracranial headache. Removing this quantity of fluid removes part of the flotation for the brain that is normally provided by the cerebrospinal fluid. The weight of the brain stretches and otherwise distorts the various dural surfaces and thereby elicits the pain that causes the headache. Migraine headache. Migraine headache is a special type of headache that is thought to result from abnormal vascular phenomena, although the exact mechanism is unknown. Migraine headaches often begin with various prodromal sensations, such as nausea, loss of vision in part of the field of vision, visual aura, and other types of sensory hallucinations. Ordinarily, the prodromal symptoms begin 30 minutes to 1 hour before the beginning of the headache. Any theory that explains migraine headache must also explain the prodromal symptoms. Migraine headache. One of the theories of the cause of migraine headaches is that prolonged emotion or tension causes reflex vasospasm of some of the arteries of the head, including arteries that supply the brain. The vasospasm theoretically produces ischemia of portions of the brain, and this is responsible for the prodromal symptoms. Then, as a result of the intense ischemia, something happens to the vascular walls, perhaps exhaustion of smooth muscle contraction, to allow the blood vessels to become flaccid and incapable of maintaining vascular tone for 24 to 48 hours. The blood pressure in the vessels causes them to dilate and pulsate intensely, and it is postulated that the excessive stretching of the walls of the arteries, including some extracranial arteries, such as the temporal artery, causes the actual pain of migraine headaches. Other theories of the cause of migraine headaches include spreading cortical depression, psychological abnormalities, and vasospasm caused by excess local potassium in the cerebral extracellular fluid. Migraine headache. There may be a genetic predisposition to migraine headaches, because a positive family history for migraine has been reported in 65 to 90% of cases. Migraine headaches also occur about twice as frequently in women as in men. Alcoholic headache. As many people have experienced, a headache usually follows an alcoholic binge. It is most likely that alcohol, because it is toxic to tissues, directly irritates the meninges and causes the intracranial pain. Headache caused by constipation. Constipation causes headache in many people. Because it has been shown that constipation headache can occur in people whose pain sensory tracts in the spinal cord have been cut, we know that this headache is not caused by nervous impulses from the colon. Therefore, it may result from absorbed toxic products or from changes in the circulatory system resulting from loss of fluid into the gut. Extracranial types of headache. Headache resulting from muscle spasm. Emotional tension often causes many of the muscles of the head, especially those muscles attached to the scalp and the neck muscles attached to the occiput, to become spastic, and it is postulated that this is one of the common causes of headache. The pain of the spastic head muscles supposedly is referred to the overlying areas of the head and gives one the same type of headache as intracranial lesions do. Headache caused by irritation of nasal and accessory nasal structures. The mucous membranes of the nose and nasal sinuses are sensitive to pain, but not intensely so. Nevertheless, infection or other irritative processes in widespread areas of the nasal structures often summit and cause headache that is referred behind the eyes or, in the case of frontal sinus infection, to the frontal surfaces of the forehead and scalp, as shown in figure. Also, pain from the lower sinuses, such as from the maxillary sinuses, can be felt in the face. Headache caused by eye disorders. Difficulty in focusing one's eyes clearly may cause excessive contraction of the eye ciliary muscles in an attempt to gain clear vision. Even though these muscles are extremely small, it is believed that tonic contraction of them can cause retroorbital headache. Also, excessive attempts to focus the eyes can result in reflex spasm in various facial and extraocular muscles, which is a possible cause of headache. A second type of headache that originates in the eyes occurs when the eyes are exposed to excessive irradiation by light rays, especially ultraviolet light. Looking at the sun or the arc of an arc welder for even a few seconds may result in headache that lasts from 24 to 48 hours. The headache sometimes results from actinic irritation of the conjunctivae, and the pain is referred to the surface of the head or retroorbitally. However, focusing intense light from an arc or the sun on the retina can also burn the retina, and this could be the cause of the headache. Thermal sensations. Thermal sensations. Thermal receptors and their excitation. The human being can perceive different gradations of cold and heat, from freezing cold to cool to indifferent to warm to hot to burning hot. Thermal gradations are discriminated by at least 3 types of sensory receptors: cold receptors, warmth receptors, and pain receptors. The pain receptors are stimulated only by extreme degrees of heat or cold and, therefore, are responsible, along with the cold and warmth receptors, for freezing cold and burning hot sensations. The cold and warmth receptors are located immediately under the skin at discrete separated spots. In most areas of the body, there are 3 to 10 times as many cold spots as warmth spots, and the number in different areas of the body varies from 15 to 25 cold spots per square centimeter in the lips to 3 to 5 cold spots per square centimeter in the finger to less than 1 cold spot per square centimeter in some broad surface areas of the trunk. Although the existence of distinctive warmth nerve endings is quite certain, based on psychological tests, they have not been identified histologically. They are presumed to be free nerve endings, because warmth signals are transmitted mainly over type C nerve fibers at transmission velocities of only 0.4 to 2 m/section. Conversely, a definitive cold receptor has been identified. It is a special, small type A delta myelinated nerve ending that branches a number of times, the tips of which protrude into the bottom surfaces of basal epidermal cells. Signals are transmitted from these receptors via type A delta nerve fibers at velocities of about 20 m/section. Some cold sensations are believed to be transmitted in type C nerve fibers as well, which suggests that some free nerve endings also might function as cold receptors. Stimulation of thermal receptors. Sensations of cold, cool, indifferent, warm, and hot. Figure shows the effects of different temperatures on the responses of 4 types of nerve fibers. 1. A pain fiber stimulated by cold. 2. A cold fiber. 3. A warmth fiber. And 4. A pain fiber stimulated by heat. Note especially that these fibers respond differently at different levels of temperature. Figure. Discharge frequencies at different skin temperatures of a cold pain fiber, a cold fiber, a warmth fiber, and a heat pain fiber. For instance, in the very cold region, only the cold pain fibers are stimulated. If the skin becomes even colder, so that it nearly freezes or actually does freeze, these fibers cannot be stimulated. As the temperature rises to plus 10 degrees to 15 degrees Celsius, the cold pain impulses cease, but the cold receptors begin to be stimulated, reaching peak stimulation at about 24 degrees Celsius and fading out slightly above 40 degrees Celsius. Above about 30 degrees Celsius, the warmth receptors begin to be stimulated, but these also fade out at about 49 degrees Celsius. Finally, at around 45 degrees Celsius, the heat pain fibers begin to be stimulated by heat and paradoxically, some of the cold fibers begin to be stimulated again, possibly because of damage to the cold endings caused by the excessive heat. For instance, in the very cold region, only the cold pain fibers are stimulated. If the skin becomes even colder, so that it nearly freezes or actually does freeze, these fibers cannot be stimulated. One can understand from figure that a person determines the different gradations of thermal sensations by the relative degrees of stimulation of the different types of endings. One can also understand why extreme degrees of both cold and heat can be painful and why both these sensations, when intense enough, may give almost the same quality of sensation, that is, freezing cold and burning hot sensations feel almost alike. Stimulatory effects of rising and falling temperature. Adaptation of thermal receptors. When a cold receptor is suddenly subjected to an abrupt fall in temperature, it becomes strongly stimulated at first, but this stimulation fades rapidly during the first few seconds and progressively more slowly during the next 30 minutes or more. In other words, the receptor adapts to a great extent, but never 100%. Thus, it is evident that the thermal senses respond markedly to changes in temperature, in addition to being able to respond to steady states of temperature. This means that when the temperature of the skin is actively falling, a person feels much colder than when the temperature remains cold at the same level. Conversely, if the temperature is actively rising, the person feels much warmer than he or she would at the same temperature if it were constant. The response to changes in temperature explains the extreme degree of heat one feels on first entering a tub of hot water and the extreme degree of cold felt on going from a heated room to the out of doors on a cold day. Mechanism of stimulation of thermal receptors. It is believed that the cold and warmth receptors are stimulated by changes in their metabolic rates, and that these changes result from the fact that temperature alters the rate of intracellular chemical reactions more than twofold for each 10 degrees Celsius change. In other words, thermal detection probably results not from direct physical effects of heat or cold on the nerve endings but from chemical stimulation of the endings as modified by temperature. Mechanism of stimulation of thermal receptors. Spatial summation of thermal sensations. Because the number of cold or warm endings in any one surface area of the body is slight, it is difficult to judge gradations of temperature when small skin areas are stimulated. However, when a large skin area is stimulated all at once, the thermal signals from the entire area summit. For instance, rapid changes in temperature as little as 0.01 degrees Celsius can be detected if this change affects the entire surface of the body simultaneously. Conversely, temperature changes 100 times as great often will not be detected when the affected skin area is only 1 square centimeter in size. Transmission of thermal signals in the nervous system. In general, thermal signals are transmitted in pathways parallel to those for pain signals. On entering the spinal cord, the signals travel for a few segments upward or downward in the tract of Lissauer and then terminate mainly in laminae I, 2, and 3 of the dorsal horns, the same as for pain. After a small amount of processing by one or more cord neurons, the signals enter long, ascending thermal fibers that cross to the opposite anterolateral sensory tract and terminate in both 1. The reticular areas of the brain stem and 2. The ventrobasal complex of the thalamus. A few thermal signals are also relayed to the cerebral somatic sensory cortex from the ventrobasal complex. Occasionally a neuron in cortical somatic sensory area I has been found by microelectrode studies to be directly responsive to either cold or warm stimuli on a specific area of the skin. However, removal of the entire cortical post-central gyrus in the human being reduces but does not abolish the ability to distinguish gradations of temperature. Diagnosis of pain and assessment of its intensity. Diagnosis of pain and assessment of its intensity. Until now, there was no way in medicine to determine the intensity of pain. There are several scales for assessing pain syndrome. All of them are based on the subjective description of pain, so comparisons from individual to individual are difficult, since pain is a multidimensional and complex phenomenon. There are scales for assessing only the intensity and reduction of pain, for example, the Visual Analog Scale, or VAS, English VAS, as well as multidimensional scales that evaluate not only the intensity of pain, but also its other characteristics, emotional, affective, cognitive, and social. The main method for assessing pain is the use of the VAS scale, figure. The VAS allows for some comparison and facilitates evaluation of treatment efficacy. The ease of use of the VAS has led to its widespread use for pain measurement in clinical trials. In addition, the VAS pain intensity scoring system is highly sensitive to changes in pain levels, especially in acute pain conditions. However, there are certain limitations in assessing chronic pain. In chronic pain syndromes, VAS has a significantly low sensitivity due to the wide diversity between patients due to the emotional, affective, and cognitive response to pain. Algimeter, from the Greek algos, Pain and metron, measure, in medicine, a device for quantitative assessment of pain sensitivity. The measure of sensitivity is a weight pressing on a metal point resting against the skin, or the force of squeezing a skin fold with forceps. In some algesimeters, skin sensitivity is determined using an electric current that irritates the skin and causes pain. The first device was invented by Bjornstrom. It was a forceps that squeezed the skin, and in fact, a scale was connected to these forceps, which determined the pain threshold. Currently there is a Norwegian device with the same name, designed primarily for anesthesiologists. Von Frey analgesiometer for animal research. The Von Frey monofilament was designed by Maximilian von Frey as an anesthesiometer in 1896. These filaments have been widely used in the assessment of mechanical nociception. The process of assessment of punctuating mechanical allodynia and hyperalgesia involves the application of von Frey filaments of forces ranging anywhere from 0.08 mN to 2940 mN and observing the withdrawal thresholds. The assay can be performed manually or by using an electric von Frey. The most commonly used method is the up-down method, wherein the tips are smoothly applied perpendicularly to the skin of the plantar surface of the subject until they buckle. However, the technique tends to be time-consuming. The electronic von Frey, EVF, is used to overcome the disadvantages of the conventional von Frey assay. The former has many advantages over the manual von Frey assay, primarily, the use of a single filament to apply varying levels of pressure. Further, unlike other tests such as the Randall-Solito test, the von Frey monofilament assay does not require restraining the subject. This approach minimizes handling and restraining anxiety which could otherwise potentially influence the performance of the subject. Headache. Headache.